So it's just like semaglutide and things.
Things like semaglutide.
Can we talk about that?
Sure.
We want the normal blood vessels, they're cool, but we
cool.
just don't want any new ones.
Exactly. We know that certain ethnicities are more predisposed to not only having diabetes, but having diabetes affect the eyes.
If I am someone with diabetes or I have a loved one with diabetes, what can I do to help to improve my diabetic control? I saw a video on TikTok and I'm bringing this, I know you're looking at me like, oh, here we go.
TikTok. The other type, should I talk about?
I feel like the people need to know.
Okay.
Welcome to this series where I ask the questions you want to know the answer to. This season, we are going to be discussing topics surrounding optometry, eye health, and eyewear. I am BD, your host, optometrist, content creator, and eyewear enthusiast. And today's question is, how does diabetes affect the eyes? To discuss this, I have an amazing guest. He is a consultant ophthalmologist, and his name is Daren Hanumunthadu. Welcome to the show.
Hi, thanks for having me.
Thanks for being here. You know, I actually didn't think you were going to say yes when I asked you. I was like,
I was slightly concerned, I'm not going to lie.
Yeah, see. And then when you said yes, I was like, oh, fantastic. We have a guest. So can you let the people know who you are, what you do, like your credentials?
Sure. So I'm a consultant ophthalmologist, or
What is that for the people who don't know?
an eye doctor or an eye surgeon. So I see people with medical and surgical related problems with their eyes.
Yeah.
My specialist interest is patients who have retinal diseases. So that includes things like diabetic eye disease, as well as conditions that are common like macular degeneration, patients who have inflammation in their eyes as well. I also do surgery, so cataract surgery, particularly with patients who have those sorts of conditions.
They're more risky.
Well, sometimes they just need a little bit of thought about how to give them the best possible outcome.
Oh, well, very well said. Look at you, Daren. You're doing great. So today I wanted to talk about the diabetes part, right? Because you said you treat patients with retinal diseases and diabetes can affect the retina. Before we get into that side of things, can we maybe do like a brief overview of diabetes, like how it affects the eye? Like, what is it? Why does it affect people?
Sure. So diabetes, or diabetes mellitus, which is its real name.
Everyone forgets the mellitus.
It
just gets left off.
Very much so. is a common condition in this country. We're talking about patients who have raised blood sugar for a sustained period of time. So the blood sugar in our bodies is organised by a hormone mostly called insulin, which is produced by the pancreas. In some patients who have type 1 diabetes, they're not producing enough insulin at all. It tends to be younger patients.
Yeah.
But the majority of patients have type 2 diabetes, where there's probably a combination of just not really responding well to that insulin and maybe a bit less too. So a common condition where patients might notice a bit of thirst or weight loss, they might get blurred vision. But for some patients, particularly the type 2 ones, they don't have any symptoms at all. And they can go being undiagnosed with diabetes for a very long time.
You know, I read on the diabetes.org.uk website that there's like almost 5 million people in the UK with diabetes, and then almost a million plus more that are like undiagnosed, just like roaming the streets.
I mean, the problem with it is that not only do they have diabetes, it's affecting their body in so many different ways.
It affects so many parts of like everywhere.
Absolutely, you know, your heart, your kidneys, your brain, your feet, and of course your eyes.
Yeah. I guess with statistics like that, right, chances are somebody who's watching this either has diabetes or knows someone who has diabetes or will get diabetes in the future. So I think it's an important topic to discuss, just to kind of like let people know, you know, what to expect and how they can kind of better look after their eyes. So how can diabetes affect the eyes? In what ways might they affect the eyes?
So probably some of the commoner things that can happen to diabetes, it can affect your prescription a little bit. Over time, the lens in the eye can start to swell a little bit and get a bit cloudier. You can develop something called cataract, which is much more common in patients with diabetes.
But do they tend to get it younger?
They do. They tend to. We kind of estimate that there's about 10 years earlier in patients who have diabetes. So it's not uncommon for me to be thinking about cataract surgery for my patients who are much younger than my other patients.
Yeah.
But I think probably the most important thing is how diabetes can affect the back of the eye.
Yeah.
So the back of the eye is the retina, and that's
sensitive film.
the light sensitive film. That's where all the magic happens. That's where the light goes into your eye and is made into messages to your brain.
Yeah.
Okay. But just like everywhere in the body, it has blood vessels.
Yeah.
Little tiny arteries, veins, capillaries, and diabetes comes along and alters those blood vessels.
Yep.
And you don't get oxygen where it needs to go. Blood pours into parts of the retina it shouldn't.
Yeah.
It blocks light. And for some people, if it's undiagnosed and not managed, it can lead to visual loss.
Which is what we're trying to avoid.
Absolutely.
With this episode.
Absolutely.
Now, I want to talk about the risk factors for diabetes, because I remember some of this from my time way back in university. Okay? And obviously the most important risk factor is that you have diabetes. You're not going to get diabetic eye disease if you're not diabetic. The other one that I remember is the length of time that you've had diabetes. So the longer you've had diabetes, the more likely there is to be diabetic eye disease, right? And so you mentioned before about type 1 and type 2 diabetes. Those with type 1 typically tend to be younger or diagnosed earlier. So by the age of 40, they might have had diabetes for like 30 years. Whereas maybe someone who's type 2 diabetic was diagnosed at 56 and, they haven't had it for as long. What are the changes that you can notice, or what is the correlation between sort of like the age and the length of time you've had it and what's the word I'm looking for? How serious or how severe the diabetic disease is?
I mean, there's definitely a association with having diabetes for a longer period of time and having worse signs of retinopathy in your eyes.
Yeah.
Particularly for our patients who are type 1 diabetes, it's a complex and difficult disease. Yeah. And you can imagine when you're a young person trying to deal with everything that you need to do, plus have to manage your sugar. It's not the easiest circumstance.
Yeah.
So I think as eye doctors, we're all really sensitive to that.
Yeah.
But at the same time, we also want to make sure that their eye health is paramount.
Especially because if they're younger, they have a lot more life to live with whatever conditions or whatever issues arise because of the diabetes.
Yeah,
right?
And often younger patients have a lot of other things going on, and sometimes we're not necessarily always taking care of ourselves as much as we should.
Guilty also.
Yeah, absolutely. And, with our type 2 diabetes patients, the difficulty is that a lot of them are diagnosed quite late.
Yeah.
And their control is often very poor. That's why they developed it. And they then come to us with already some retinopathy and some changes that we need to manage.
You're almost like trying to chase your tail to try and resolve things. What other risk factors are there for diabetic eye disease?
So sugar is really important, but other things that are important are things like blood pressure, cholesterol, not to smoke, doing regular exercise. We know that sometimes if you're pregnant and have diabetes, the chance of it affecting or causing more problems in your eyes is a little bit higher.
Yeah.
So often we tend to see those patients a little bit more frequently. We know if you have kidney problems, you might have a bit more problems with your eyes. Then there are all these sorts of things that you can't really deal with. So how long you've had diabetes for in particular. We know that certain ethnicities are more predisposed to not only having diabetes, but having diabetes affect the eyes. And we don't really know why that is. It's a complex relationship.
What ethnicities are those? Like, who should be more...
South Asian patients, Afro-Caribbean patients, patients from East Asia. Absolutely. And, we all have different bodies, and even how these conditions affect our eyes and the treatment that we give, it's always going to be different from individual to individual as well.
It's like case by case basis, right?
Absolutely.
In the UK, we like to screen our patients. I guess try and make sure that we can catch them before anything gets too bad. What is the process like here for people who either maybe just got referred to a screening service or people who are not from here who want to know how it works? How would you sort of describe that process?
I'm actually really glad you asked about that because the thing is, diabetic eye screening, we are the world leader in it.
Are we now?
We have a national diabetic screening program where patients who have diabetes can come, have specialist photographs. The photographs are then had a look by someone who's trained to look at them, and hopefully they're all fine.
Everything's fine.
Hopefully they're all fine.
See you again in a year.
Absolutely. But if there's any changes that are a bit concerning, they might refer you to the hospital eye service for a specialist optometrist like yourself, or an eye doctor like myself to have a look. And that's really important because a lot of the time with diabetic eye changes, there are no symptoms.
Yeah.
And early detection, early treatment can be really key.
And even sometimes when you might see some scans and you might see some fluid at the macula, or you might see some changes that you think are quite severe, but their vision is okay.
Yeah.
And so sometimes I find it really hard to try and get the message across that, look, babe, we're trying to save your vision here. Yeah. Because actually they can see. And it's really difficult to say, like, things are changing if they don't feel that things are changing. And sometimes by the time the vision changes, then there's a lot more damage to the eye. It's not harder to kind of resolve it.
I mean, talking to patients is really key.
Yeah.
And we're really lucky in eyes because we have photographs.
Yes, we have proof.
We have proof. So we can show someone exactly what they're seeing, what we're seeing in their eyes.
And compare between, look, this was last time, this was this time.
And I think that's really powerful.
Yeah.
And I think, a lot of the things that we talk about in medicine and ophthalmology are a little bit abstract. But being able to show how this is how it should be and this is how yours is changing. This is why you need to do this to try to look after yourself, and this is why we need to do this to try to look after you.
And that bit as well, even saying like, this is why we need to do this treatment. So you mentioned doing like macular clinics, macular degeneration, right?
Yeah.
With patients, sometimes it's like you're giving them these treatments and they're not always the most pleasant treatments, and they have to have them multiple times sometimes. And to be able to show them a scan and say, look, this is what it looked like before, look at this improvement now, it kind of is motivating. It kind of helps them to be like, oh, okay, cool. Like, I can.
Oh, 100%.
I'm actually helping.
I think we're in a sort of partnership with the patients with all the treatments that we're giving.
Yeah.
They have to give a lot to be able to look after themselves, but also to come to appointments and have that treatment.
Yeah. And be waiting for ages and ages
and ages. Time off from work, time off away from family.
People having to bring them and take time off of work. So many things that go into it. I want to talk about diabetic control.
Okay.
Because I feel like it's something that we say to patients, control your diabetes. I will type on the letters, make sure you can, maintain good diabetic control while I sit there eating my Haribos, right? So I feel like it's very easy to say and much harder to do, right? If I am someone with diabetes or I have a loved one with diabetes, what can I do to help to improve my diabetic control?
I think the first thing to think about is trying to probably get as informed as yourself as the patient. Okay, so we're really lucky now that there's lots of good information out there about diabetes.
Yeah.
So learning about your diet, how particular foods affect your body is really key.
Yeah.
Learning about how to incorporate regular exercise is really important.
Yeah.
Knowing about things like how it might be your blood pressure, so salt, all the good things, right?
Yeah,
salt,
all
sugar,
the good things.
Obviously don't smoke.
Yeah,
that's
not a good thing.
That's not a good thing. But, in this day and age, I still have to say it to my patients. It's really important.
And it's hard, I guess, to quit once you started. So it's really easy to be like, oh, yeah, just stop smoking. But someone who's been smoking for 20 years, it's kind of like, babe.
Sure, and I think it's really easy for us to tell the patients that, you need to do this. But I think it's important that they know, because if it's affecting your eyes, and vision is so precious, right?
Yeah.
They should be aware of it. And there are sort of services that we can signpost them to.
Yeah.
NHS support stop smoking services, which for many patients have been really, really helpful.
Yeah.
But obviously after that, it's about the medications they're on, optimizing those medications. There are lots of newer sorts of treatments that are available for patients with diabetes.
So it's just like semaglutide and things.
Things like semaglutide.
Can we talk about that?
Sure.
So how does that work? Because I feel like, obviously, what's it called? Like, what's the name of it?
Ozempic,
Zempi, yes. So I feel like it's gotten quite a negative rep because people are maybe using it for weight loss. But that wasn't really the intended use, right?
Yeah, I mean, it was first thought about for managing for patients with diabetes.
Yeah.
And we know that one of the ways that it works is to delay food from going through your body, delay gastric emptying.
Right.
So that makes you feel more full.
So then
therefore
you eat less. Okay.
So people call it hunger noise, food noise. That's it, food noise. So it reduces that food noise in your head.
Oh, like, I need to eat something. So the cravings kind of stop.
Exactly.
Right,
so
okay.
Therefore, your sugar intake reduces, your blood sugar control gets better as well.
Mm-hmm.
And this is a really important tool for diabetologists, GPs, endocrinologists to help patients.
Yeah.
It's a relatively new drug.
Yeah.
And I think one of the things that we have to think about is when we've got patients with these new medications, is there anything that might be affecting the eye, whether it's positive or negative?
Mm-hmm.
So I always say, be really upfront with your with your doctor about it, because a lot of patients are just buying this online now.
Yeah, that's the other thing, right?
Yeah,
The black market.
Absolutely. So we want to know. So if you're starting something new, let us know, because we might want to monitor you a bit slightly more differently.
Yeah.
Maybe see you a bit more frequently, just to make sure that everything is okay in your eyes.
And I guess as like clinicians, we have to make patients feel comfortable enough to say things, because I feel like sometimes they might feel that judged, and they don't want to tell us certain things because they're like, oh, they're going to tell me not to buy this thing.
Yeah, I think sometimes it's incumbent upon us to bring it up before they tell us.
Yeah.
Just so we create
a safe space. Yeah.
Yeah. And hopefully it'll get easier and easier, because I think so many of my patients are on it and now, and many of them, maybe they don't feel ready to say.
Yeah.
But it's important that we kind of
that we know.
So if there's anything else going on in their eyes that we can help with, we can.
Is if you are on like semaglutide or something like that, say you stop taking it, then do the effects stop? So do you have to keep taking it? Kind of like if you're on metformin, you would keep taking metformin, right?
Yeah, so we think that when you're on semaglutide, the effect of the medication probably does wear off as you stop taking it.
Mm-hmm.
But that doesn't necessarily mean a bad thing. It might mean that you'll be able to control your sugar in other ways.
Okay, well, thanks for that. That wasn't on my cards, but I'm glad we discussed it. So what else can we do to improve diabetic control? So diet, exercise, stop smoking. Are those the main things?
Those are the main things, and they're really those sorts of things that we should be incorporated into our daily lives.
Yeah.
And I think the most important thing is probably thinking about consistency.
Oh yeah.
Yeah. So yeah, there's a whole week, Monday to Sunday, and we should try to think about, not
don't forget Tuesday, Wednesday, Thursday, Friday.
Exactly, and we're all a little bit guilty of that, but
Absolutely.
Consistency is definitely key.
Do you know what I think as well, in terms of like if you're a relative of someone with diabetes, or maybe they're your partner or whatever, like having like a little accountability buddy system, right? So maybe you also stop smoking. Maybe you also eat less Haribos with the person, so that you can both, kind of like vibe off each other.
Oh, absolutely. And if you've got type 2 diabetes, hey, it's actually in your interest too, because we know that there are some genetic factors that are related. So, you're looking after yourself, you're looking after your family member too. And I have a lot of patients who say it's really difficult to look after myself because, they have lots of people they're looking after as well.
Yeah, it depends on them.
Yeah, absolutely. But, one of the things I always say is you need to be able to look after yourself before you're going to look after anyone else.
They say on the airplane, you've got to put your mask on first. You've got to put your mask on first before you help anyone else.
Maybe I'll use that analogy later.
No, you have to. No, seriously, it counts for everything in life. So I have a question. I saw a video on TikTok, and I'm bringing this. I know you're looking at me like, oh,
TikTok.
On TikTok, yes. And you know why I thought I'm going to ask this question? Because I feel like a lot of people, they see stuff on TikTok or Facebook or Twitter, because I'm never calling it X, but they see stuff on Twitter, and they just see that, and then that's it, right? And I think some things like are right, but sometimes we don't then maybe look deeper or ask a professional if to fact check what it is that we've seen. So I'm going to ask this question. I saw a video on TikTok, and the person was basically saying that with diabetes, it takes years for the dietary changes to... So, for example, if I am diagnosed as diabetic today, I didn't just become diabetic. Maybe 10 years ago, what I was doing led to me becoming diabetic today. Is that true?
I think there's probably some truth in the fact that things didn't happen overnight. Mm-hmm. Whether or not it's 10 years.
Yeah, it was 10 years specifically.
Yeah,
I was like,
I'm not sure if it's that, if we can be that specific.
No, it's this arbitrary number.
Yeah, but particularly in type 2 diabetes, it's the way your body responds to sugar.
Yeah.
So that's definitely going to be something that changes slowly over time. I don't think anyone can put a specific number of years, and it'll probably vary from person to person quite significantly. But I think what's important is probably also that means that when you control it, it's not going to be
So this was my next question.
Yeah.
This was my next question, because oftentimes when we're looking at images and writing to patients about their diabetes, they will have said in their history and symptoms, I've got great diabetic control, I'm doing really well. But when we look at the scans, maybe there's a small improvement, maybe no improvement, maybe it's even slightly worse. And you're not thinking, oh, the patient's lying, they're over there eating Jaffa cakes, yeah. But it would make sense then that, okay, if you have just gotten good control over the past month or so, that wouldn't maybe show up just yet.
Yeah, I think some of the changes that can happen do take time for it to cause an effect.
Yeah.
And we know that from how we've looked at patients for a long period of time and the way they progress with their diabetes.
Yeah.
I think it can be a little bit tricky for patients who then say, you know, they come to us in the clinic and they say everything's been fine for ages, why are things getting worse? And that's a really difficult situation.
Yeah.
I think one of the things to know, and probably I should say, is that we want sugar to be under control, but sometimes if it's really, really good control, there's some evidence to suggest that if you do that really, really quickly, there can be problems in the eyes.
If it's like sudden,
exactly.
It's like what you were saying about consistency, right?
Exactly,
Like it has to kind of just be a slow, steady.
Yeah, and speak to your ophthalmologist, speak to your eye doctor, speak to your specialist optician, because there are some medications that we're thinking about now, things like fenofibrates, to help prevent retinopathy as well.
What's that?
So that's a tablet that's given to help reduce lipids, so like cholesterol in your body.
Fats and stuff.
Exactly. So, and there's some evidence that actually independent of the effects of cholesterol or lipid fats, it might help to stop the diabetic retinopathy from worsening. So it's something always to think about and talk about with your eye care team.
So say the diabetic retinopathy does worsen. On occasion, a patient might require some treatment.
Yeah.
What can that look like? If my mum said, oh no, they've said I need to have treatment, or when we write in the letters, oh, please control your diabetes, treatment may be required if it gets worse. What does that treatment look like?
So broadly speaking, there are two main forms of eye treatment. There's a laser treatment. Okay, so we apply a specialist retinal laser using a very precise microscope in the clinic.
And this is different to LASIK, which people often conflate with.
So we love lasers in ophthalmology.
We love a bit of laser. It does so much.
We do all these different types of lasers. There's
what
LASIK
were we doing before laser? No, for real. What were we doing?
We've been using them for a long time. There's lasers for eye pressure, and there's lasers for the retina too. So we apply that little laser onto the back of the eye, sometimes in a few sessions, and that's really to try to prevent more advanced diabetic eye changes. It doesn't improve your vision. It's not like LASIK.
You will still need glasses.
You still need glasses. But it's all about preventing significant visual problems long term. The other type, should I talk about?
I feel like the people need to know.
So the other type is always a bit of a conversation with patients when I start to bring it up. There are a range of medications that we can inject inside the eye nowadays. And those medications help work against blood vessels. They stop the blood vessels from growing. They also stop these abnormal blood vessels from leaking fluid that then damages your retina.
Because we want the normal blood vessels. They're cool. But we just don't want any new ones.
Exactly.
Like the door is closed. So we don't want any new blood vessels. We want the ones that we have and we're happy.
And these medications work very well.
And
we have lots and lots of them. And if I tell you now that in terms of treatment for eyes, in the UK we do more eye injections than we do any sort of eye treatments.
Do you know what? I was going to say, do we really? But that actually makes a lot of sense.
We do. When you think about not just for diabetic eye changes, for a lot of other eye conditions too, but it's a very common treatment. And we've got all sorts of new medications that are coming now to help.
Such fun.
We've got steroid injections and things like that too. And of course there are patients who have a more advanced sort of change in their eye and they might need operations as well.
But that's like way over here.
Absolutely, and we kind of want to try to avoid that.
Everything we've discussed so far is to prevent it from getting to that stage. So that's almost like a last resort.
Absolutely, but it works well for some patients, and it's important that we have it kind of as
an option,
something in our arsenal at the back.
Just like wait.
If needed, and sometimes it is required.
I just want to say thank you very much for being here.
Thank you.
I have one last question for you.
Okay.
I know, so it feels like a quiz, doesn't it? It was so dramatic.
We're building up to it. I'm really wondering what you're going to ask.
Breathe. Do you have any advice for somebody who is watching this, who maybe is diabetic or knows a diabetic or anything diabetic related?
I think particularly for eye care, I'm going to go back to the screening program and I'm going to say, go to your eye care checks. You know, you might not have any symptoms, but go and get the photographs done. And if there's something that's unusual in it, an eye care professional will be able to review that for you before you have any symptoms and let you know what's going on with your eyes. And hey, if there's a problem that you need to come to the eye hospital, we'll see you and we'll work together to try to manage your condition.
Can I add on to that? When you get seen at the diabetic screening clinic, that does not constitute an eye test, right?
No.
Because you still need to have an eye test, because at the diabetic screening clinic, they're not necessarily looking for other things, although they do spot many things. And again, another reason why the screening service is amazing. But say, for example, there were changes to the vision and things. Sometimes I have patients who are like, yeah, I went to my screening clinic, or they've never had an eye test ever, or they had one when they were 14, and then they've been seen at the screening clinic and then nothing.
So we should all of us, every single person, whether or not you have diabetes or not, you should be seeing your optician on the high street every 1 to 2 years.
Yeah.
Because in addition to looking for glasses,
yeah,
they screen for a variety of conditions.
So many things.
And the screening program, as you say, they check vision.
They do really well,
and they see lots of other things.
So many random things.
But we all need to be able to look after our eyes really carefully.
Yeah. Thank you so much for being here.
Thank you. Thanks for having me.
Wait, no, one last thing.
Okay.
So you do private treatment, don't you, Daren?
I do.
So can you tell us about that? If the people want to find you, if they want a private cataract surgery done by yours truly, how can they find you?
Find me. So you can see me at Kersey Eye Clinic, which is in central London.
I'll put the link. Send me the link. I'll add it to the
Perfect. I'll be pleased to see you about cataracts or diabetic eye changes or other retinal conditions. Inflammation too.
All the things. Fantastic. Okay, brilliant. Is that everything? It sure is. What else do I need to say to end this thing? That's it. Thank you so much for being here. How did you find it?
It was okay. It was less stressful than I thought it was going to be.
I told you, it's going to be calm vibes, chill vibes.
Yeah, and you didn't ask anything I didn't know the answers to.
Yeah, because you're a surgeon. Because you're a surgeon, you know everything. Okay, brilliant. What time are we at?